This is episode 82 of the Psychcast by MDedge, where we bring you interviews with leaders in the field, masterclass lectures, and relevant inspiration straight to your ears with new episodes dropping on Wednesdays. I'm the voice of MDedge Podcast's Nick Andrews. Coming up later, the editor-in-chief of MDedge Psychiatry, Dr. Lorenzo Norris, welcomes Dr. Susan Hatters Friedman for a conversation on postpartum depression. And Dr. RK is back this week for a talk on ethical rigor. The interview portion of this episode starts around the 5 or 6 minute mark. You can find the exact timestamps in the podcast notes. Before we begin, a quick reminder that you can email the show and participate in any of the episodes with your feedback by emailing us at podcasts@mdedge.com. It's time now for This Week in Psychiatry. This week we continue coverage of the opioid epidemic and opioid use disorder. Prescribing buprenorphine for the treatment of opioid use disorder requires strict discernment on the part of clinicians. That's the message that Dr. Podesta delivered at the 2019 Annual Psych Congress in San Diego. Dr. Podesta is a board-certified psychiatrist who subspecializes in addiction medicine and practices in New Orleans. She advised clinicians to be prepared for a visit from the DEA, to understand the unique properties of buprenorphine, and to make sure that patients grasp the importance of sublingual administration. She said that researchers show that only 5% of physicians are allowed to prescribe buprenorphine, which is an opioid, by way of a DEA waiver. About half do not prescribe the drug. Barriers to prescribing buprenorphine include factors such as low reimbursement and untrained support staff. However, she did note that the Substance Abuse and Mental Health Services Administration has recommended that medication-assisted therapy, which is with methadone, buprenorphine, and naltrexone, should be considered in all patients with opioid use disorder. She said that when used correctly, the drugs are safe and effective. Being aware of buprenorphine's unique properties is important. The drug is safer on the overdose front than the other opioids, Dr. Podesta said, but it can be very dangerous in patients without opioid tolerance. According to the DEA, as an analgesic, buprenorphine is 20 to 30 times more potent than morphine. Also, like morphine, patients who take buprenorphine are likely to experience euphoria, papillary restriction, and respiratory depression and sedation. The reason that naloxone is part of the combo is because as an add-on, it reduces the risk of buprenorphine will be crushed and snorted for an opioid high. Dr. Podesta also suggested that clinicians drop the use of the word contracts to describe treatment agreements between patients and clinicians. She said to call it an agreement because it seems more mutual and less punitive or risky for the patient to sign, especially when they're in a precarious comfort zone. Remember, you can find a link to the story in the show notes this week and every week on This Week in Psychiatry. Okay, it's time now for the interview with Dr. Lorenzo Norris and Dr. Susan Hatters Friedman.
Hi, I'm Susan Hatters Friedman. I'm currently the Phillip Resnick Professor of Forensic Psychiatry and also Professor of Reproductive Biology and Pediatrics at Case Western Reserve University. I'm both a forensic and perinatal or reproductive psychiatrist, and I am one of the authors of the recent piece in Current Psychiatry about postpartum psychosis that came out in April 2019.
Hello, this is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. I'm so pleased to have with us today Dr. Hatters Friedman, who is going to be talking with us today about postpartum psychosis and really just highlighting some different things that as practicing clinicians that we should be thinking about when treating this condition. So Dr. Hatters Friedman, please welcome to the MDedge Psychcast.
Thanks, I'm excited to be here.
So Dr. Hatters Friedman, let's just kind of get right into it. Postpartum psychosis. It occurs, it's serious, and I believe that you have said this on a different occasion when I've spoken to you, but I completely agree with you being a CL psychiatrist. Postpartum psychosis is a medical emergency, point blank in the discussion, in my humble opinion, and it needs to be treated as such with a sense of not only curiosity but urgency. So please, go for it.
So postpartum psychosis, it's important to remember that it's not only a psychotic disorder picture. These women are presenting usually in the first 3 to 10 days postpartum, which means they're usually back at home unless their baby's in the neonatal intensive care unit, and they're caring for this infant. Now, in addition to symptoms of psychosis, they often experience symptoms of mania, including dysphoric mania, so you may be seeing symptoms all along the mood spectrum. And as well, they may have a confusion-like picture similar to delirium. So very fulminant experience of symptoms across the psychiatric spectrum, and they develop quickly. It's not like delusions at other points in schizophrenia, for example, that develop slowly over time. These are false beliefs that may develop very quickly and change over time.
One of the things I always would think about in terms of postpartum psychosis, I almost encourage many of my residents, you really need to, it is as serious and it can be as different and like have all the symptoms associated with a delirium. And a delirium can present with every symptom under the book. So I agree with you that it certainly can present in different ways. I think another thing that when people are thinking about postpartum psychosis, at least when I'm teaching residents, some people will have they'll incorrectly think, oh, well, Dr. Norris, the patient didn't have a prior psychiatric history, so, they most likely don't have a postpartum psychosis. I'm like, no, that's actually completely wrong. Even though it's true, very true, that postpartum psychosis frequently is occurring in patients with a history of bipolar disorder or who may go on to develop a history of bipolar disorder. My understanding of it is that there can be a large number of patients that don't have a diagnosed psychiatric history, so we have to still be vigilant with any type of that rapid development of psychiatric symptoms, particularly if it's associated with any type of fluctuation in consciousness.
I would completely agree. So yes, as you said, it's most commonly associated with bipolar disorder, but everyone has to have their first episode of bipolar disorder at some point. Women who are of childbearing age are well within the range to start experiencing bipolar disorder symptoms as well. So yeah, it may very well be her first presentation to mental health. When you're talking about things developing and changing quickly as we were, I think another important point is collateral information.
Absolutely.
Because things may change over time in the course of the emergency room visit. And as well, the mother who has any insight that something is going wrong with her may also have the fear that if she tells you something's going wrong, you're going to snatch away her baby. And she wants to avoid that. So she may purposely be concealing her symptoms, or they may have changed over the course of time since someone brought her into the emergency room.
That we need to actually dwell on or think about that just a moment, because to me the key in regards to getting that diagnosis or even being able to work with the patient is establishing that relationship. I think that your ability to elicit any type of symptoms or to work collaboratively with the patient is going to just be stopped cold if they do not sense obviously a sense of warmth from you, but also that you are working in the best interest of the patient and their child. So I think to me that's one of the key things, because again, just kind of going back to my roots in terms of teaching, residents or younger clinicians will go in, but they won't set the stage in terms of establishing some form of alliance. And without that, particularly in a situation in which a mother has just given birth, I personally think that your ability to assist, help, and work with this family is going to be significantly limited just based off of what you said, because the vast majority of mothers are not going to want to even entertain the idea of their child getting taken away from them.
Yes, I agree.
Now, one of the things in terms of thinking about postpartum psychosis, it's a medical emergency. It requires treatment. How do you actually work with the family in trying to explain to them what's going on?
So in explaining to the family what's going on, as with anything, you try and explain the diagnosis, but also the risk stemming from the diagnosis. And you want to get the family on board, if possible, that treatment of the mother is in everybody's best interest. I mean, certainly you could involuntarily hospitalize her, and in many cases you may need to, but having the family on board and understanding the importance of keeping the baby and the mother safe while we're getting this treated and under control is important.
Okay. All right. I want to touch base on that idea of involuntary hospitalization a little bit later in the psychcast, but I want to even go back a couple of steps further. All right. So we know that postpartum psychosis in general is rare, but we know that in patients with bipolar disorder or schizophrenia, but I'm going to focus on bipolar disorder, that we can have a reasonable number of patients, depending on the study that you look at, I want to say anywhere from like 25 to 40% of patients with bipolar disorder can have postpartum psychosis. That gets into this idea of being proactive and psychoeducation. And Dr. Hatters Friedman, I was wondering if you could comment on that a bit.
Sure. I think that that's a very important message for us about being proactive with any woman of childbearing age who's our patient, whether she has bipolar disorder or another mental health issue. So often you might see a patient who says she's not planning pregnancy, but we know in the general population, but moreover in the population in need of mental health services, that many pregnancies are unplanned. So doing psychoeducation about pregnancy, about contraception, and about the natural course of mental disorders, both in pregnancy and the postpartum, is very important in our patient population so that we can be proactive and preventative where possible. So if someone has a history of bipolar disorder, what we want to be doing is talking to them about the possibility of pregnancy and thinking about medications that are relatively safe in pregnancy, even if she's telling us she's not planning to get pregnant, because it can happen by accident. And the smart thing is to already be on something that's relatively safe in pregnancy. So I'm talking preconception, but then when someone is pregnant, continuing to talk about the medications and the other treatment options, therapy, et cetera, the importance of getting a good night's sleep, et cetera, because that's a risk factor as well. But then also proactively educating about the postpartum and the risks if you're a woman with bipolar disorder, both of postpartum psychosis as well as postpartum depression, and thinking about medication to prevent, thinking about strategies at home to help prevent, whether getting someone to help at nighttime or if the partner can help at night so that she can get a good sleep where possible is important as well.
I'm all about being proactive as well as the psychoeducation. Now, one of the things, just to ask you just directly, do medications work to prevent postpartum psychosis or mood episodes if taken prophylactically in the postpartum period?
Yes.
Yes.
And a common strategy that we're going to use, yes.
Absolutely. So, yeah, just to put that out there for everybody, yes, it absolutely works. Now, the challenge sometimes that I come up with, and I'm very curious in regards to your approach to this, Dr. Hatters Friedman, is with mothers in terms of breastfeeding. All right. Always a very important discussion in regards to the use of psychotropic medications in the postpartum period, particularly in mothers that are breastfeeding. And I don't know if you have any thoughts or views on that, or what is your take?
So stepping back from that, it's important to, where possible, be in touch with their pediatrician as well as the mom and her partner so that everybody's on the same page about medications. Part of the being proactive is talking about breastfeeding when the woman's pregnant as well, and thinking about what medications are relatively safe in pregnancy and are also relatively safe in breastfeeding so that you're not even worried about changing medications at delivery or something like that. So thinking in the long term about this plan to breastfeed. I also think it's important that, though we all know breast is best, that we have reasonable conversations with women and with mothers about it. Sometimes I've had the experience of patients feeling incredibly guilty, wanting not to have the baby exposed to any medications, but at the same time wanting to breastfeed. And so talking about the risks and benefits is important, as well as letting her know that there are sometimes you supplement with formula feeds, et cetera.
We want to make sure that we are respecting the mother and the family's choice, and mother's choice in particular, in regards to breastfeeding. Where I've gotten tripped up before is when I haven't started those conversations early. When you're trying to start the conversation, like really right there in the postpartum period, and at that point in time, people aren't really able, it becomes a little bit more difficult to consider all of the differing options. And in this particular context, I'm talking about patients that have a known psychiatric history or a history of bipolar disorder, and we're trying to work to actually prevent a mood episode of some sort or a postpartum psychosis. I do feel as though when you look at the evidence base in terms of the postpartum period, I think it's one of, particularly what I'm talking about for those with bipolar disorder, not just women in general, but those with bipolar disorder specifically, I think it's one of the most dangerous periods potentially out there. As we mentioned before, there can be anywhere from a 25 to 40% risk of developing a postpartum psychosis, which in my mind, sometimes that's actually a delirium. We say that the postpartum psychosis can present with delirious symptoms, but the way I kind of think about it, if you meet criteria for delirium, that's going to trump everything else. So I actually think it most certainly can present in that fashion. And the other thing is, and again, I'm going to have to make sure that I've got the study correct on this, but I want to say that the suicide rate in the postpartum period can be increased by anywhere from 50 to 70-fold, and I want to say suicide is the leading cause of maternal death 1 year after delivery. So when I add all of that up, when I just think about it, I try to keep things simple. This is a period of time where we really need to be vigilant with our patients. That postpartum period, all of pregnancy period, but that period in particular, because, and I'm speaking with in regards to patients with bipolar disorder, this is a very serious period that requires medical attention from all members of the team, OB-GYN, pediatrician, as well as psychiatry.
Exactly, and I think you're stressing the importance of communication between the different disciplines of healthcare, and yeah, as other causes of postpartum death, such as infection, et cetera, have gone down, suicide has become a leading cause of death, actually responsible for 1 in 5 postpartum deaths, so 20%. And then when we're thinking in postpartum psychosis as well, of the risk of disorganization related to the delirium-like piece of it, being unable to care for your child, they could accidentally die from something like that, or a purposeful act, the child could be killed. So it's really part of why we're talking about it being a psychiatric emergency, because of the risks of suicide and homicide.
Dr. Hatters Friedman, let's say you're teaching either junior faculty or residents. If you had to pick 3 important things that they needed to keep in mind, either when diagnosing or treating the patient for postpartum psychosis, what would those things be?
I think I would come back to the picture including not just psychosis, but the mood symptoms and the delirium-like symptoms. And of course, you're going to work up the delirium medically as well, but not wanting to miss those cases. I think that the second thing that I stress with residents is the importance of collateral and realizing that this presentation can change very quickly over time, so that a mother may be masking her symptoms because of the worries about child protective services that we talked about, or she may be looking better now than she did a couple hours ago, but that doesn't mean she's better or she's not unwell. So it's really exploring what's been going on. And then I would also stress the association with bipolar disorder in particular, and thinking about this with our patients proactively.
Okay. You brought up earlier, at times there is going to be a need for involuntary hospitalization. And what I was curious about is how you actually, if you need to hospitalize, you need to hospitalize. But interestingly enough, sometimes I find that when you're working in a team-based setting, a lot of people can have resistance to taking a mother away from her child or newborn child. And I was wondering if you had any insight or tips that you could share with us in terms of how you navigate that at times potentially tense situation.
Absolutely agree that it can be a tense situation with the family or with the team. This is not what they expected when they were pregnant and going home with the baby. So we talked earlier about navigating this with the family, but the treatment team members or folks in the ED or in the obstetric unit may have strong feelings about her needing to stay together with the baby. And so what I do really is a careful risk assessment, thinking about her risk of suicide and of violence or homicide, and make sure that I'm communicating that risk and the importance of the hospitalization to those team members, while still saying, yes, of course, the bonding is important, but she's in a space right now where the safety of her and the baby is the most important thing right now. And when she's getting better in a few days, will be time to continue the bonding work.
You know, when I think about it, when I've been in situations like this, it is very stressful, and there can be a lot of tension. The idea of doing a thorough assessment, everybody knowing you're doing a thorough assessment and being detailed and emphasizing the communication, I feel is exceedingly important. I do want to go back to or mention a point that you talked about in terms of being proactive about the education. In hospital settings, I think sometimes we can lose the art of liaison in terms of working with people, but working with them early, particularly teams. And I think if you are fortunate enough to have either a good relationship with your OB-GYN department or pediatrician department, that's one of those times where if you all give an in-service or a lecture, if you prep the teams ahead of time that this is an emergency, that at times this is required, and we can get good outcomes if we act in a very efficient fashion, I think it makes things go, I won't say a lot smoother, but at least gives you some foundational elements in which to talk about. So I really liked what you said, and I also like what you said earlier about that proactive education component. And I would encourage listeners, particularly if they're in hospital settings, to push that not only for the patients, but also with the team members that they may be working with. All right. So, Dr. Hatters Friedman, I want to thank you so very much in regards to speaking with us in regards to postpartum psychosis. This is an exceedingly relevant topic. I think that we could spend 3 or 4 more podcasts talking about it, and I actually think that we may have to have you back just to talk in general about women's mental health, period, and not just about postpartum psychosis. So I want to thank you for coming on the MDedge Psychcast and sharing your wisdom with us.
Thanks very much.
And that's it for the interview portion of our show. We'll be right back with Dr. RK. Welcome back to the Psychcast by MDedge. It's time now for Dr. Renee Kohansky.
Thank you, Nick, for the introduction. Psychiatry has at various times been the red-headed stepchild of medicine. Of course, in these increasingly daredevil times, one must be cautious about near everything. Red is my hair color these days, so I feel comfortable speaking of red, and psychiatry is my chosen profession. Mary, Queen of Scots, was a redhead, but we know what happened to her precious head. Are you all enjoying this loosening of associations minute here with Dr. RK? But listen, in actuality, where I'm going in fact is we mustn't lose our collective heads. My colleagues, we have fought long and hard to be recognized as a legitimate and authentic specialty of the medical field. I recently read an interview by Dr. Phillip Resnick. He had been consulted upon in the Cleveland shooting case and provided a classic Dr. Resnick answer. Dr. Resnick said, and I quote, "It ended up kind of a mystery as to what his, the shooter, real motives were. He just wasn't forthcoming. Even after spending hours with him, I don't know what really went on." Now, Dr. Resnick is a renowned forensic psychiatrist, and one of the many things I believe makes Dr. Resnick so very good at what he does is his wisdom and his courage to say, "I don't know," when he doesn't know, even after spending hours with the defendant. He just doesn't make up stuff. In Dr. Resnick's position, one could so easily be manipulated by either defense or prosecution to achieve an end. Physicians like Dr. Resnick not only give forensic psychiatry a good name, they give psychiatry a good name. And there are many others like him. It's what attracted me to the field of forensic psychiatry. And by the way, it's not limited to forensic psychiatry. I spoke of Dr. Charles Raison in a previous program and his intriguing findings about the impact of antidepressants. He, too, spoke of a difficult truth, or dared to ask a difficult question, because, as I've said again and again, that's what we do. And that's what we must continue to do. We need to ask difficult questions, and we just can't make up stuff. And right now, more than ever, we must be ever vigilant to unspoken agendas. In our role as physicians, as distinct, by the way, from a forensic evaluator, we are indeed advocates for our patients. But the advocacy is a subtle advocacy. By advocacy, I mean we are for our patients. We are in their court, as it were. But we must always be careful to speak what we know to be true. And when we don't know, to say we don't know, we can't declare a truth just because we wish it were so, or because the forces of our time try to command a truth or a direction. We must demand of ourselves as much rigor as we can ethically allow, and then state the limits within that. I'm Dr. Renee Kohansky for the MDedge Psychcast.
And that's a wrap on episode 84 of the Psychcast by MDedge. Let's give credit where credit is due. The Psychcast is hosted by MDedge Psychiatry Editor-in-Chief Dr. Lorenzo Norris. The Dr. RK portion of the show is written, recorded, and produced by Dr. Renee Kohansky. MDedge Psychcast audio producers are Gina Henderson and Jeff Bauer. MDedge podcasts are produced by executive editors Denise Fulton and Kathy Scarbeck. MDedge multimedia editor Terry Rudd. Our social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MDedge Podcast's Nick Andrews. You've been listening to the Psychcast by MDedge.